we have limited. So we do not have much time. So I'm just going to generally discuss about schizophrenia, depression, bipolar disorder, anxiety, insomnia, substance use disorders, alcohol, opioid dependence, and tobacco dependence. So our first topic is it's schizophrenia. So schizophrenia is a chronic, severe, and disabling thought disorder that occur in 1% of all societies, regardless of class, color, religion, or culture. So basically, this is a disorder in which dopamine and glutamate is not working properly, or if you have access. In order to diagnose this disease, the DSM-5 identifies 5 symptoms for diagnosis that has to be present at least 2 of the following symptoms for 1 month. So those symptoms are delusion, disorganized speech, negative symptoms, hallucination, disorganized or catatonic behavior. So if we are going to categorize these symptoms are categorized into 3: positive, negative, and cognitive impaired. So positive means something is there that does not supposed to be there. In negative means that sometimes symptom that something has to be present, but that is not present, like alogia. Alogia is called dysfunction of speaking. Anhedonia means reduced ability to experience pleasure. And under positive symptoms, it is hallucination, means perception of something. Delusion means false belief. And like cognitive impairment means working memory, does not learn from mistakes. So if we are talking mainly, we have to focus on antipsychotic treatment. And antipsychotic treatments are divided into 2 classes. The first one is typical or conventional older antipsychotics, and the second one is second generation, that is also called atypical antipsychotic. Those are newer agent, and so if we are talking about those 2 agents, we have to think about for first generation or typical antipsychotic. Those have higher mortality rate than second generation when used in older adults with dementia. And it has a black box warning against use in older adults with dementia. So just keep in mind. And for second generation antipsychotic, we have to think about the risk of EPS, that is extrapyramidal side effects, is lower. The risk of tardive dyskinesia is reduced, and it has also ability to block serotonin 2 receptors. Under first generation antipsychotic, it has haldol, flufenazine, thioxine. We can see all that. And when we are thinking about antipsychotic, we have to think about high potency, moderate potency, and low potency. If the antipsychotic has high potency, it means it has more EPS side effects. Means we have to think about all those EPS, tardive dyskinesia, ataxia. And I would encourage you guys to memorize these high, moderate, and low potency antipsychotic. And then, as I said, that for extrapyramidal side effect, we have to know about what are those symptoms, like Parkinson type syndromes, in which patient has rigidity, tremor, or akinesia. Then acute dystonia, ataxia, and tardive dyskinesia. And if we are talking about these side effects, we need to know how we are going, if patient is experiencing those side effects, how we are going to treat those. So if, for example, if patient has akinesia, rigidity, tremor, we normally treat with diphenhydramine, trihexylphenidal, and benzotropine. And those has very typical dose, like if we are talking about diphenhydramine, that's a Benadryl. The dose for that is 25 to 50 milligram BID. And if we are talking about benzotropine, all those have anticholinergic activity. and they are going to have like the dose will be 0.5 to 1 milligram once or twice a day. If patient is experiencing acute dyskinesia, we normally treat with anticholinergic, that's benzotropine. Same as ataxia, I would say that need to memorize for if patient is experiencing ataxia, means patient is restlessness, then we normally treat with beta blockers, specifically propranolol and nadolol. If a patient is going to develop tardive dyskinesia, normally those are abnormal involuntary movements that occur with long-term antipsychotic therapy. In this case, the treatment is decreased dose of antipsychotic or switch to clozapine. We are switching to clozapine normally when all those agents are not working, and if avoid anticholinergic symptoms. So as I said that for any first generation antipsychotic, we have high, moderate, and low potency. If we are going to use high potency antipsychotic, the side effects, as I said, is tardive dyskinesia or NMS. NMS is a disease, is a symptoms that is called neuroleptic malignant syndromes, in which it occurs. It could be possible with all agents, but appear more commonly with high potency first generation antipsychotic. And the typical symptoms are agitation, confusion, changing levels of consciousness, fever, tachycardia, sweating, and high blood pressure. Treatment for those, treatment for neuroleptic malignant syndrome, normally we immediately has to discontinue the agent. Supportive therapy, including fluids and cooling, bromocriptine, and dantrolene. So if we are, then those are the main points for first generation antipsychotic. If we are talking about second generation antipsychotic, so those are normally clozapine, olanzapine, quetiapine, risperidone, those are the common one, and Latuda and zypresidone. And if we are talking about and thinking about second generation antipsychotic, I would say that we need to know which antipsychotic has most metabolic side effect, EPS, hematological effects, QT prolongation, which one can increase prolactin, and which one has more risk for seizures. So if we are talking about metabolic side effect, we divide into highest, moderate, and low risk. And I would encourage you to memorize all those agents that has metabolic side effect. The most highest risk for metabolic side effect are clozapine, olanzapine, and quetiapine. Moderate risk are associated with risperidone, paliperidone, and the lowest one is with the aripiprazole, zypresidone, lurasidone, and Snris. If we are talking about EPS, the lowest risk is with quetiapine. And whenever we are talking, whenever we have clozapine, we have to think about agranulocytosis because it can reduce WBC very quickly, and patient has to be monitored once the therapy is going to start. Patient has to monitor every week for first 6 months, then every 2 weeks for next 6 months, and then every month for next 6 months, and so on. Here in this chart, this is typically representing the same thing that I told you. This is the most simplified version of antipsychotic side effects. So I think this chart is very important, and you guys need to know very well. Also, later in my presentation, you will see that we have case studies and we have to choose which antipsychotic is the best. Then we talk about the therapy duration. Then this is just like some first episode patient may be tired of drugs after being symptoms free for 2 years, and then those with a history of multiple episodes should probably be symptoms free 5 years. After discontinuation, and complete remission without symptoms is uncommon. Then this is the case number one in this, like in this study. The question is a 25-year-old man with BMI of 35. Always, whenever we are talking about antipsychotic, as I said, that we all antipsychotic has metabolic side effects, so we have to think about that. If patient is already obese or overweight, we have to be careful which antipsychotic we are going to choose. We are not going to choose the one that is going to increase weight more, or for example, if they have like high, and also the one of the side effects of these antipsychotic is to have to effect on blood sugar. So if patient is diabetes, we have to choose also very carefully. So he often how I'm going to get rid of this sidebar? I can't see my screen.
Ma'am, you may use the slideshow option.
Slideshow option? Okay, I got it. Where is my slideshow?
I guess it is in the
okay,
bottom.
I got it. Yeah. So case number one is a 25-year-old man with BMI of 35. So definitely this is an obese man. Was recently given a diagnosis of schizophrenia. He often hears voices telling him that he's stupid and worthless and that he should just jump off his apartment building. His parents became very concerned about his isolative behavior and brought him to the hospital. He was giving Haldol. Here, if we are talking about Haldol, we have to think about this. Haldol has a high potency antipsychotic. So what side effect would be possible? In the psych department and now present with neck stiffness and his oculogyric crisis. Now, until now, he has not taken medication because he felt that he could control his symptoms on his own with vitamins and energy drinks. Though he has difficulty remembering to take these, he has an additional history of marijuana and alcohol use disorders. So which is most appropriate for this patient symptoms at this time? Our options are benzotropine, dantrolene, lorazepam, and propranolol. So as I said, that this is a Haldol that has high potency for EPS, and neck stiffness is one of the symptoms. So in this case, like option A is the best option, that is benzotropine. It has anticholinergic side. This is anticholinergic. Dantrolene we normally use in neuroleptic malignant syndrome. Propranolol is not an appropriate agent, and also Ativan is not the right treatment in this case. Then question number 2 is he's initiated on aripiprazole, which is the best rationale for this selection. Options are aripiprazole has minimum risk of causing extrapyramidal side effect. B, aripiprazole is available in a long-acting injection to increase adherence. C, aripiprazole would decrease this patient negative symptoms, and aripiprazole is only dosed once daily. So the best option is, in this case, is aripiprazole is available in a long-acting injection to increase adherence, as the question said that he does not remember to take his multivitamins or medication. So if we are going to start this patient on aripiprazole, later we can convert this patient to twice weekly or every month injections of aripiprazole. Then next question is, I'm going to skip question number 3 and go to case number 4.
Sorry to disturb you, ma'am. You may also use the page view option for the full screen.
Full screen? Okay. Where is that,
Page
Prida?
view in the title bar at the top. Page view option.
I'm sorry. More. It says new shared chat participant security mute. I'm not seeing.
No problem, ma'am. You may continue.
I'm sorry.
No problem.
Okay, case number 4, 1 year later, he no longer responds to aripiprazole and you decide to change his medication. He's only interested in oral medication, giving this patient history, which is the most appropriate this time. We have option for clozapine, fluphenazine, olanzapine, and ziprasidone. And the best option in this case is ziprasidone. Because based on the history, he had acute dystonia. So ziprasidone has the lowest risk for causing that symptoms. The next topic is depression. So depression is like a major depression is one of the most common health conditions in the world. People with depression suffer greatly with persistent feelings.
Ma'am, your voice is not clear.
Okay, maybe I was
Yes,
far from my computer. Can you hear me?
No problem. Yes,
Okay.
it's clear now.
It's clear now. Okay. People with depression suffer greatly with persistent feeling of hopelessness, rejection, consistent worry, poor concentration, lack of energy, and inability to sleep, and some cite suicidal ideation. So this is again the cause of depression are poorly understood, but involve some combination of genetic, biologic, and environmental factors and neurotransmitters believed to be involved in depression, such as serotonin 5-HT, glutamate, acetylcholine, dopamine, and norepinephrine. If patient has at least 5 of these following symptoms almost every day for at least 2 weeks, patients are identified that they have depression. Sometimes we use different scale. Some of them, the most common one are HAM-D, PHQ-9. These are just a scale that we use for the diagnosis. So diagnosis and treatment for mood disorders are different since it is not possible to measure brain chemical imbalances. That's why we have to use all these scaling and grading criteria to diagnose patient for major depressive disorder. Again, we will focus on treatment options available. Different treatment options that are available are psychotherapy. We normally start treating patients with the psychotherapy, and if it is not working, then we go for pharmacological therapies that I'm going to discuss. And the last resort is like electroconvulsive therapy, that those are reserved for refractory depression. In this type of treatment, temporary memory loss is common. And we start this treatment when the symptoms are severe or life-threatening. So if you are talking about treatments options, first line medication are SSRI, SNRI most of the time. And if those are not, bupropion and mirtazapine. In our common practice, we do not see tricyclic antidepressant as a first line agent, but those are still there. Monoamine oxidase, those are also available, but we do not see in practice very common. So the first one, the first treatment is SSRI. In SSRI, we have agents available like fluoxetine, sertraline, paroxetine, citalopram, and escitalopram. And fluoxamine are mainly like reserved for OCDs. If you are talking about those agents, we just have to think about general side effects. So the most common side effects for these agents are nausea, vomiting, sexual dysfunction. And particularly if you are talking about each individual, fluoxetine has the longest half-life and is most activating. Paroxetine has a side effect for weight gain, and this is the most sedating agent. Citalopram and escitalopram, if we are using over 40 milligram, then it may cause QT prolongation. If patient is experiencing sexual dysfunction, we may add bupropion. And also the other options are, Viagra may be beneficial for men. Also, we need to keep in mind that if we are talking about SSRIs or SNRIs, we need to think about serotonin syndrome. And I'm going to talk in my next slide. Also, for one more common side effect for the SSRIs are bone fracture and hyponatremia we have to think about. So nausea, vomiting, headaches, sexual dysfunction, QT prolongation, bone fracture, and electrolyte disturbance, mainly sodium. All those are the common side effects for SSRIs. The next one is SNRIs. In this class of medication, we mainly talk about, or we see in practice, venlafaxine and duloxetine. If we are talking about venlafaxine, we have to think about increased blood pressure. And this is most common if patient use doses higher than 150 milligram per day. For duloxetine, this medication is used also for diabetic peripheral neuropathy, fibromyalgia, and chronic musculoskeletal pain caused by chronic lower back pain or osteoarthritis pain. Also, when we are talking about these SSRIs and SNRIs, we have to think about CYP interaction. The last one, levomelnacipran, you will not see in practice very often, but this is one of the FDA approved treatment for fibromyalgia. Tricyclic antidepressant is you will not see in practice very often because it has side effects. Four most common side effects, those are anticholinergic, sedation, orthostatic hypotension, and cardiac toxicity. And the last one is monoamine oxidase, also is not very common in practice. And when patient is taking this monoamine oxidase inhibitor, they have to avoid food high in tyramine. For example, cheese, preserved meat, And then if they are going to start this, they have to have 2 weeks for short period. And if we are talking about long-acting SSRIs like fluoxetine, it has to be for 5 to 6 weeks. For major depression, sometimes you see combination of SSRIs and SNRIs. Patients are taking, and also it is not uncommon to see patient on SSRIs or mirtazapine if they have any, um, if they have any, if they are losing weight. In serotonin syndrome, this is just a slide for discussing the serotonin syndrome. Symptoms are neuromuscular hyperactivity like rigidity, tremors, and altered mental status like agitation, confusion, hyponatremia, and they have like very high temperature. Treatment is almost same as like as we discussed in neuroleptic malignant syndrome, like discontinue the offending agent, supportive measure like if patient has very high fever, cooling blanket, and respiratory assistance. If patient is developing seizures, normally we treat with clonazepam and aspirin for hypothermia. Other antidepressants that are available are bupropion, trazodone, and mirtazapine. If we are talking about those agents, we need to think about specifically bupropion. If we add to SSRIs, it improves sexual function. This is also used for smoking cessation, and the name for maybe the brand name may be different over there, but here it is called Zyban. It may decrease appetite and increase the risk of seizures. So if patient has already seizures, this agent is not the agent of choice for those people. Trazodone is used for insomnia. So for lower doses, it is used for insomnia, and with higher doses, it is used for depression. And mirtazapine increase appetite, weight gain, and the other side effect it has is constipation. So if you have like very frail elderly that has depression and decreased appetite, normally the agent you choose is mirtazapine. Or if a patient have like sleep disturbance due to depression, trazodone is the best option. And in this slide, this is just telling you that normally it takes about 4 to 6 weeks, and you see full effects up to like in 12 weeks. So in continuation, keep the symptoms in remission by using full dose therapy, duration normally 4 to 9 additional months. So for SSRIs and SNRIs, just keep in mind that you will see full effects in 4 to 6 weeks. Combination therapies, as I said, that very common in practice: SSRIs plus trazodone, SNRIs plus mirtazapine, SSRIs plus bupropion. And also there are therapies available like antipsychotics, sometimes used for depression, and the most common one that are FDA approved are aripiprazole. You will see in practice quetiapine mostly, and the combination of olanzapine plus fluoxetine. Other treatment options that are available like lithium, modafinil, and scopolamine, but those are not very common, but you can see that. So the next case is a 45-year-old woman has a medical history significant for sleep apnea, hypertension, type 2 diabetes, chronic pain, and bulimia. She is in the clinic today for an assessment of her depressive symptoms and a medication evaluation. She endorses sad mood, poor appetite, poor concentration, and feelings of hopelessness and worthlessness for the past 3 weeks. She has also stopped going to her book club because she is not motivated to get out of the house, and she has frequent nocturnal awakening. She denies suicidal or homicidal ideation. She denies any use of alcohol, tobacco, or illicit drugs. She currently takes hydrochlorothiazide, metformin, hydrocodone, acetaminophen, and aspirin. Her current BMI is 20, that's in normal range. And her blood pressure today is 152/94, that's a high blood pressure. She reports adherence to her current medication. So here, the question is, which selective serotonin reuptake inhibitor would most likely interact with her current medication? Here now, as I said, we have to think about CYP interaction. So we have to keep in mind which one is CYP inhibitor, which one is a CYP substrate or inducer. In this case, the best answer is C, which selective serotonin most likely interact with her medication. So the answer is C, paroxetine. And the reason is interaction with this patient current medication, because this is the CYP inhibitor and it is going to interact with narco. Narco is the hydrocodone and acetaminophen. Next question is, which antidepressant would be most appropriate for her depressive symptoms? Options are bupropion, fluoxetine, mirtazapine, and venlafaxine. So the best answer is answer C, mirtazapine, because she has poor appetite and she has difficulty sleeping. Question number 7 is, it has been 4 weeks since her initial visit with you and she has been treated with citalopram 20 milligram per day. In the morning, she's still present with sad mood, but her insomnia, concentration, and appetite have improved. She still has feelings of hopelessness and worthlessness, lack of motivation, and anhedonia. She has no adverse effect at this point, which is the best recommendation to optimize her therapy. Options are continue at current dose of 20 milligram per day, increase the current dose to 40, add aripiprazole, or change to a different SSRIs. So in this case, if patient is stable and improving symptoms and the dose has not reached to maximum, so normally we increase the dose. So the best answer is answer B, to increase the current dose to 40 milligram. Next question is, 6 months later, she reports that although her depression symptoms have resolved, she has trouble during intercourse, which is quite disturbing to her. You determine that she has an orgasmia caused by citalopram treatment, which is the most appropriate recommendation at this time. So the best answer in this case is answer B, because as I said, that if patient is experiencing sexual side effects, bupropion is the best option to add. So the next topic I'm going to discuss is bipolar disorder. In bipolar disorder, we just have to know that bipolar disorder is also a mood disorder in which mood can fluctuate from extremely sad or hopelessness state of depression to an abnormally elevated.
Dr. Shama, your voice is not clear.
Can you hear me?
Yeah, doctor, it's perfect now.
Okay, I'm sorry if okay, so I will start over. So the next topic is bipolar disorder. Bipolar disorder is also a mood disorder in which mood can fluctuate from extremely sad or hopelessness state of depression to an abnormally elevated, overexcited, or irritable mood called mania or hypomania. So whenever we are talking about bipolar disorder 1 and 2, and if we start treatment, we have to make sure that in which state patient has. Bipolar 1 and bipolar 2, we have, these are the different classification based on DSM-5. Normally, we see either bipolar 1, that's chronic disorder marked by one or more manic or mixed episode and major depressive disorders. And bipolar 2 is chronic disorder, same marked by one or more major depressive episode accompanied by at least one hypomanic state. The other two are not very common, but still they are there. These are the treatment options. So lithium, anticonvulsant, Depakote, carbamazepine, and lamotrigine, that is called Lamictal, and few antipsychotic are also used in a bipolar disease. We can also use benzodiazepine like lorazepam or diazepam for acute agitation. Patients are experiencing bipolar. So here, if we are talking about lithium, we just have to memorize few important points. Lithium levels and dose, lithium toxicity. And if we are talking about lithium toxicity, we have to keep in mind for ACE inhibitors, NSAID, and thiazides. Those are the ones that can mainly cause lithium toxicity if patient is taking these medication. Lithium is teratogenic in pregnancy, so you have to keep in mind if patient is pregnant, you have to choose accordingly. Most common side effects are rash, tremor, CNS agitation, nausea, vomiting, diarrhea, hypothyroidism, and teratogenicity, as I said, avoid during first trimester. Our next case study is a 26-year-old man with a history of type 1 bipolar disorder present to the inpatient unit. His wife found that he was withdrawing their life savings from the bank. He states that he is the perfect candidate for the presidency. He is hyperverbal, so it means that he is in hyper state and has not slept in the past 48 hours. He's placed on a 72-hour hold for control of his manic symptoms. He has a history of non-adherence to medications and currently taking none. Takes none. GL last hospitalization was 2 months ago when he had significant depressive symptoms and suicidal ideation. He has 3 or 4 hospitalizations per year, and his history of medication trials include olanzapine and Lamictal. He has also received a diagnosis of hepatitis C with an AST of 175 and ALT of 186. So in this case, he's in hyper state, and the question is which mood stabilizer is most appropriate for this patient at this time. We have again 4 options, and the best option is option D, because most of the time lithium should be initiated to treat the current manic episode. Yes, in the current episodes. The next question is which treatment emergent adverse effect would be of most concern and would require immediate evaluation if he were prescribed lithium? Options are hypothyroidism, tremor, severe acne, weight gain. And the best option in this case is answer B, tremor, because tremor may indicate lithium toxicity and will require an immediate evaluation of the patient lithium concentration. The next question is 3 months later, he has been stable on lithium 900 milligram per day. However, during a clinic visit, he's confused and slurring his words. His current lithium serum concentration is 1.9. He has been taking lisinopril and torvastatin again for his hypertension and dyslipidemia for 2 months. He takes zolpidem for sleep. He began running a week ago. He has been replacing fluid using an oral rehydration solution, Gatorade, and taking ibuprofen around the clock for pain. His other medication includes lisinopril, atorvastatin, and zolpidem, which most likely contribute to this patient current clinical situation. So here the options are which can cause this lithium toxicity: Gatorade, ibuprofen, lisinopril, and zolpidem. And the best answer in this case is ibuprofen. So those are answers. So so ibuprofen is the best answer in this case because it can cause lithium toxicity. Lisinopril can cause lithium toxicity, but in this case, because patient has been taking lisinopril for past 2 months and has not developed any symptoms, and he just recently started to take ibuprofen. So in this case, the best answer is B, ibuprofen. Then next question is a 36-year-old woman, BMI 20, that's a normal rate, with type 1 bipolar disorder present to your clinic, tearful, with a 2 weeks history of depressed mood, anhedonia, insomnia, feeling of worthlessness, and loss of appetite. She has passive thoughts of suicide, but no concrete plan. She currently takes lithium with a trough serum concentration of 1.1. Which medication would be best to treat her current episode? So in this case, option C is the best option, because if we are going to choose Lamictal has to titrate slowly. Hello?
Yes,
Hi,
Dr. Shama.
Okay, thank you. Okay, now I'm just going to talk about the next topic, anxiety disorder. Give me a second, please. Okay, here again, I'm going to focus on treatment, anxiety disorder, what treatment is the first line option and the most commonly used. So if you are talking about anxiety, we have general anxiety disorder, OCD, and trauma. And in most of the cases, if you are talking about generalized disorder, general anxiety disorder, SSRIs and SRIs are mostly used. Again, I'm going to talk just like case study because we are not going to have more time to cover everything. So in this case, case number 13, a recent Iraq war veteran has been treated successfully with paroxetine for his major depression for the past 3 weeks. He present to the clinic experiencing nightmares, feeling on edge all the time and having flashbacks of his time in the war. He's evaluated and giving a diagnosis of post-traumatic stress disorder. He has no history of substance dependence and no significant medical history. Which recommendation is most appropriate for this patient at this time? Our options are continue paroxetine because it treats both PTSD and major depression. Number B is discontinue paroxetine and initiate sertraline, which treats both PTSD and major depression. C, continue paroxetine and add lorazepam for the anxiety symptoms. And D, discontinue paroxetine and initiate buspar for the anxiety symptoms. So the best option is answer A, because paroxetine should be continued at this time because the patient is successfully being treated for depression and paroxetine is considered a first-line agent. Again, in this case, if we are talking about each disease state, we need to know which one is the first line and second line agent and which one is the best treatment options. Next question is a 48-year-old man has newly diagnosed generalized anxiety disorder. He cannot sleep at night. He reports frequent headaches, which he treats with ibuprofen. His family history is positive for depression. His mother is positive for anxiety, and sister has an anxiety disorder. Which medication would be the best for long-term resolution for his symptoms? Options are alprazolam, buspar, paroxetine, and pregabalin. So in this case, the best option is option C, because both SSRIs and SNRIs are first-line agents. Pregabalin is not approved for anxiety disorder, and we can use alprazolam, but in this case, we are not going to use it. Next question is that 27-year-old woman with panic disorder is having difficulty functioning at work. She had her first panic attack while getting a cup of coffee. She felt she was having a heart attack and was seen at the local ED where physical causes were ruled out. She has had several subsequent episodes. She cannot predict when or where they will happen. Her absence from work is high and she's concerned about the job. Her medical history is otherwise unremarkable. Which medication would most quickly allow her to return to work? Options are alprazolam, buspar, paroxetine, and venlafaxine. If she has acute panic attack, the best option are option A, because buspar can take time to start working. Next question is a 21-year-old woman has newly diagnosed OCD. She's unable to hold a job because she is also consumed by her obsession and compulsion. She's convinced that her obsessions are reality, which is most appropriate to initiate. In this case, the best option is option B, again, that is SSRI, that's the first line agent.
Ma'am, your voice is not clear.
I'm sorry, but I don't know what should I do to make it clear. Is it like cutting, or you cannot hear me, or maybe that's the internet issue? Hello?
Yes, ma'am, you
Now
may
it's clear.
continue.
Okay. So the next topic is insomnia. Insomnia is a condition in which patient is not able to sleep. And insomnia is diagnosed when the patient has symptoms for at least 3 times per week and at least for 3 months. So again, you have different treatment options available. So you have benzodiazepine, non-benzodiazepine, and others. Under other, as I said, that the most common one are trazodone. If those are used in a low doses, it can be used for to treat insomnia. Diphenhydramine, that's a Benadryl, is available as an OTC product. Doxylamine, those are commonly used to treat insomnia, but those are not a good option for elderly population because of the anticholinergic side effects. So for benzos, for benzodiazepine, so different benzodiazepine options are available like triazolam, temazepam. So some are short acting and some are long actings, and the other non-benzodiazepine options are those are the one like Lunesta, Sonata. Those are the non-benzodiazepine options commonly used in practice. The most common side effects of benzodiazepines are residual daytime sedation, and those are common with long-acting agents. So when we are choosing benzodiazepine, we have to think about if patient has any liver or if liver disease, or which benzodiazepines we are going to use in elderly patients. So normally in elderly patient, we use LOT. Those are lorazepam, oxcazepam, and temazepam. The next case is a 38-year-old kindergartner teacher present to the clinic today with noticeable dark circle under her eye. She has difficulty with sleep, mainly with staying asleep. It takes her about 20 minutes to fall asleep, but after about 2 hours, she wakes up and cannot fall asleep again for several hours. This pattern has taken a role on her job and she feels tired all the time. She once took diphenhydramine for sleep but had to miss work because of extreme drowsiness in the morning. She wonders whether she can take any other medications. Her other medical problem include hypothyroidism. For that, she is taking levothyroxine 125 microgram at bedtime. Hypertension, hydrochlorothiazide, she takes 25 milligram in the morning. Chronic back pain, she normally takes ibuprofen 800 milligram 3 times a day. And for her mood, she takes citalopram 20 milligram in the morning. So the question is, which agent is most likely contributing to her insomnia? Options are citalopram, hydrochlorothiazide, ibuprofen, and levothyroxine. So the best answer in this case is levothyroxine. Normally levothyroxine, if you take in the levothyroxine, normally you take in the morning, and she's taking at that time. So I would say that switch levothyroxine from that time to the morning dose. Citalopram can also cause her insomnia, but she is taking in the morning, so that is not a possibility. And hydrochlorothiazide and ibuprofen doesn't have any role in this case. The next question is, which medication used for insomnia is most appropriate to recommend for this patient? Option number 1 is Lunesta, Trazodone, temazepam, or Sonata D. So the best option in this case is option A, because most of the time, option A is the one that helps to staying asleep. Which adverse effect of zolpidem would carry the greatest potential for harm in her? Option number A, orthostasis, disorientation, abdominal behaviors while asleep, seizures with high doses of the drug. In question number 19, they are asking about the side effects, and the most common side effects for zolpidem is option C, abnormal behaviors while sleeping. So the next one is alcohol abuse. Alcohol is a CNS depressant and the most common used to abuse. So alcohol abuse, if patient has alcohol withdrawals, it have different stages. You can see in stage 1, 2, 3, and 4, and those are the time that those symptoms, patient may experience those symptoms. So first to 6 hours, most common side effects are tremor, agitation, restlessness, and if you see day 3 to 5, they have delirium, confusion, agitation, tremor. And so the most acute treatment for alcohol withdrawal is benzodiazepines. Benzodiazepines, most commonly you will see lorazepam, diazepam, and Librium, that is epoxide. And if we are going to choose benzodiazepine, we just have to keep in mind which one is cleared by liver and which one are not. So if patient has liver disease, you can choose lorazepam, and diazepams are most commonly used if patient has withdrawal with seizures. For chronic therapy, you can use disulfiram, but if patient has history of liver disease, disulfiram is not a good option. For any liver disease patient and has to be on maintenance therapy, acamprosate is the best option. And also those patients are nutrient deficient, so you will see that you have to give 100 milligram of thiamine initially as IV treatment and then transition to PO. Fluid therapy is also common, like half normal saline or normal saline with dextrose. Question number 20, a 50-year-old patient with a 25-year history of alcohol dependence was found unconscious after his last drinking binge. He was first admitted to the medical unit for alcohol withdrawal symptoms before being transferred to the substance dependence unit. His last drink was 6 hours ago and fluid has been initiated. He has had 3 alcohol withdrawal seizures in the past and an episode of delirium treatment. He also has significant hepatitis and liver function tests show AST of 220, ALT of 200. Additional laboratory test value include albumin, alkaline phosphate, total bilirubin, prothrombin time, second platelet count, and creatinine, 72 ml per minute. Question is, which symptoms are you most likely to observe in the medical unit in this patient? Options are alcohol craving, delirium, tremor, increased heart rate, or seizures. So the best option in this case is answer C, because the initial symptoms of alcohol withdrawal include like increased heart rate, blood pressure, and then alcohol craving, delirium treatment, and seizures generally occur after 12 hours of abstinence. You can see in the chart, the timeline, when patients are going to experience symptoms the most. Next question is, which agent is best for his alcohol withdrawal symptoms? Options are Librium, clonazepam, diazepam, and lorazepam. And the best option is lorazepam, because this patient, if you can see, the AST and ALT are elevated. So it means that something is going on in the liver. So the best option is lorazepam. So as I said, that whenever we are choosing agent, we have to keep in mind if patient liver function is normal or not. Because you know that alcohol, for any alcohol patient, it is very common to have liver disease. Again, the next question is emphasizing on which medication is best for his alcohol dependence. We have to keep in mind that if patient has liver disease or not. So the option A is the best option because patient has history of liver disease. So if we are talking about opioid dependence, the next one is opioid dependence. And in opioid dependence, we just have to keep in mind which agents are the best option for the maintenance or for the acute treatment. So normally in practice, if patient has opioid dependence, we have to treat with Suboxone. That's the combination of buprenorphine and naloxone. So treatment is it has 4 phases like induction phase, stabilization phase, maintenance, and discontinuation. So those are the one if patients are on short-acting opioids, short-acting opioids like dilaudid, hydromorphone, oxycodone, and heroin. So we can treat those patients with Suboxone. That's again is a combination of buprenorphine and naloxone. And if patient is on long-acting opioid like methadone or OxyContin, we have to start with methadone 30 milligram per day. So the question for opioid dependence is a 34-year-old man wants to stop using oxycodone. He has oxycodone. So here we have to keep in mind that which medication they have been taking and addicted. So in this case is oxycodone. That's a short-acting opioid. He has been buying it off the street and is using 160 milligram daily. He is not interested in methadone maintenance. He would like to enroll in an outpatient program. He is 24 hours, his last dose. He is having some anxiety and muscle aches. He will start his treatment in the clinic, which is the best formulation and dose to initiate in this patient. So options are buprenorphine 2 milligram, buprenorphine 4 milligram, and a combination product that is buprenorphine naloxone 2:1 or 4:1. So normally we start treatment with 4:1. So option D is the best option. And our last topic is tobacco dependence. In tobacco dependence, we just have to the most common. So in tobacco dependence, you will hear 5 A's, very common in practice. 5 A's are asked about tobacco use, advice to quit, access means if they are willing to attempt to quit and assist in quitting process, and arrange. So those are 5 A's you will hear. There are different treatment options available: patches, gum, lozenges, inhaler, and nasal spray. In practice, you will see patch, gum, and lozenges. Those are available as an OTC product and called nicotine replacement therapy. There are also prescription products available. That's bupropion, as I said earlier. The specific product, the name for smoking cessation for bupropion is Zyban. But Zyban is contraindicating in eating disorder, seizure disorder, bipolar disease, and if patient has been using any recent monoamine oxidase use. Normally, it has started 7 days before the quit date and for at least 8 weeks up to 6 months. The other option that is available is Varicilline, that's Gentex. This medication is also started 1 week before the quit date, but it has a black box warning of neuropsychiatric symptoms. You have to be cautious if patient has any kidney disease. Sometimes you may get this question like, oh, patient still wants to quit, patient wants to start nicotine replacement therapy, or like they want to quit smoking, but they still want to keep smoking. So in this case, you have to know which agent you can use if patient still wants to keep smoking and gradually reduce the number of cigarettes per day. It's like you can recommend Chantix or bupropion or patch as a nicotine replacement therapy, but gum and lozenges has to be stopped. But if patient wants to use gum and lozenges, they should have to stop smoking. So this is just a summary slide in which it tells you which agent may cause weight gain, weight loss, disulfide effects, hepatotoxicity you have to keep in mind, drugs that are not supposed to use if patient have seizure disorder, and QT prolongation. And always keep in mind all these agents. You have like which one is CYP inhibitor, which one is a CYP substrate, which one is a substrate and which one is an inducer and an inhibitor, and which one you can use if you cannot use if patient is a smoker or if patient is taking any anti-TB medication like rifampin. So these are just like the summary points you have to keep in mind. So we are all done for today. Let me know if you have any questions.
Okay, thank you so much, Dr. Shama, for such an informative session. We would like to request our participants, if they have any queries, they may share. They may open their mics and share their questions. Do we have any questions? Okay, so we will share the slide and lecture content with the participants in the group. If they have any queries, then we will forward it to Dr. Shama, and we'll get back the answers to our participants later on. Thank you so much, Dr. Shama, for giving us time from your tough schedule. And also, thank you so much, participants, for being with us. If you want to say anything regarding the topic, you may say, Dr. Shama. Okay, so our next lecture topic will be on infectious diseases on 5th Feb. Sorry, let me check the dates again. Sorry, it will be on Saturday, 15th Feb, on infectious diseases part 1, that will be presented to us by Dr. Muhammad Rehan. Till then, thank you everyone. We'll meet you in the next lecture. Allah Hafiz.
Allah Hafiz. Thank you very much.